Today we are going to discuss coagulants and anticoagulants. So first of all we'll discuss about the hemostasis or coagulation part. Spontaneous arrest of bleeding from damaged blood vessel. What is hemostasis? Spontaneous arrest of bleeding from damaged blood vessel. Means if there is any minor cut or prick or is there any sharp injury, so that bleeding stops after few minutes, right? That spontaneous arrest of bleeding from the damaged blood vessel, we call it as a hemostasis. We have seen so much of time. We'll get some small prick because of some needle, because of some sharp object or something like that. So immediately what happens? There is a spontaneous, naturally there is an arrest of bleeding. Bleeding stops from the damaged blood vessel and we call it as a hemostasis. Now in this hemostasis, there is an interaction between injured blood vessel wall. There is an injured blood vessel wall. There is a platelets and coagulation factors. So it involves complex interaction between injured vessel wall, platelets and coagulation factors. So what are the events after vascular injury? Whenever there is a vascular injury, the first thing that occurs is the arteriolar vasoconstriction. The first thing that occurs is the arteriolar vasoconstriction. This arteriolar vasoconstriction is because of endothelin, which releases from the vascular endothelium. There is a arteriolar vasoconstriction. Then second thing, there is a primary hemostasis, means the formation of the platelet plug. Formation of the platelet plug. And then there is a secondary hemostasis in the form of deposition of fibrin. And then clot stabilization, and ultimately there will be a resorption of clot. So these are the events after vascular injury. Now when we say hemostasis or coagulation of the blood, so these are the factors which involved in the blood coagulation. There are 13 factors, like factor 1 fibrinogen, we know that. Factor 2 prothrombin. Factor 1 is a fibrinogen. Factor 2 is prothrombin. Factor 3 is a tissue factor or thromboplastin. Factor 4 is the calcium. Okay, calcium plays very important role in a blood coagulation. Then factor 5 is a labile factor, or we call it as proacceleratin or accelerator globulin. Okay, factor 6 presence has not been yet proved. Then factor 7 is the stable factor. Factor 8 is the anti-hemophilic factor. Factor 9 is the Christmas factor. Factor 10 Stewart-Prower factor. Factor 11 plasma thromboplastin. Factor 12 Hegman's factor. Factor 13 fibrin stabilizing factor. So all these factors plays very important role in blood coagulation. Now we'll see coagulation cascade. As this coagulation cascade, there are two pathways, intrinsic pathway and extrinsic pathway. So as you can see, intrinsic pathway means inside the blood vessel. Inside the blood or inside the blood vessel, when this factor number 12, as you can see in the intrinsic pathway, factor number 12, when it comes in contact with injured blood vessel, platelet, there is an activation of factor number 12. 12A. A means there is an activated factor number 12. So this factor number 12, which get activated by contact, so it helps in conversion of factor number 11 to the activated factor number 11. Means is Factor number 12A is responsible for activation of factor number 11 with the help of high molecular weight kininogen and kallikrein. High molecular weight kininogen and kallikrein. Now activated factor number 11 helps in conversion of factor number 9 to the activated factor number 9 with the help of calcium. Now factor number 9, or we can say activated factor number 9, converts factor number 10 to the activated factor number 10 with the help of calcium, with the help of platelet phospholipid and calcium. Right? Now there is a activated factor number 10. Now this activated factor number 10, what does it do? With the help of factor number 5, with the help of platelet phospholipid, with the help of calcium, it converts prothrombin to the thrombin. Prothrombin is converted into thrombin. And thrombin helps in conversion of fibrinogen to the fibrin, which is soluble in nature. Now this fibrin is converted into insoluble form with the help of factor number 13, which is the fibrin stabilizing factor. And thrombin also helps in this. So ultimately, what we have to make, that fibrin molecule which is insoluble form. How will you make it? That fibrin molecule insoluble? Soluble fibrin is converted into insoluble fibrin with the help of two things. Factor number 13 and thrombin. Okay. Now, how come fibrinogen is converted into fibrin? Fibrinogen is converted into fibrin with the help of thrombin. Right? Now, fibrinogen is converted into fibrin with the help of thrombin. And this prothrombin is converted into thrombin with the help of activated factor number 10, factor number 5, platelet phospholipid and calcium. This is the intrinsic pathway or intrinsic system. Now, where is the extrinsic system? This intrinsic system is very slow. Now, extrinsic system, when there is a bleeding, when there is a tissue damage, when that vessel wall damages and bleeding occurs, when it crosses that vascular endothelium, there is a activation of factor number 7. There is activation of factor number 7 with the help of kallikrein, factor number 12A, factor number 11A, and there is activation of factor number 7. Now this factor number 7 helps in activation of factor number 10 with the help of tissue factor and calcium, and again there is the activation of factor number 10, and the rest of the process will remain same. Means factor number 10 plays a common role in intrinsic and extrinsic pathway. Once there is an activation of factor number 10, then this factor number 10 with the help of factor number 5, calcium, platelet phospholipid, this factor number 10 converts prothrombin to the thrombin. Now thrombin helps in conversion of fibrinogen to fibrin. This fibrin is soluble in nature. With the help of thrombin and factor number 13A, this soluble fibrin is converted into insoluble fibrin, and this is what is our coagulation cascade. Now we'll see the coagulants or haemostatics. Substances which promote coagulation and are indicated in the hemorrhagic states. Coagulants or haemostatics. Substances which promote coagulation. If there is any minor cut, as I told you in the beginning, so your bleeding has to stop, right? So substances which promote coagulation and are indicated in the hemorrhagic states. So we have vitamin K, which is fat soluble. Fat soluble form of vitamin K is menadione. Acetonaphthone, water soluble form of vitamin K is a menadione, sodium bisulfite. Miscellaneous coagulants like fibrinogen or human fibrinogen, antihemophilic factor, desmopressin, adrenochrome ethamsialate. Now, first of all, we'll see vitamin K. This vitamin K is a fat-soluble vitamin. We know what are the other fat-soluble vitamin? A, D, E, K. So, K is a fat-soluble vitamin. Now, what is the function or significance of vitamin K? It is essential for biosynthesis of clotting factors. Essential for biosynthesis of clotting factors. So, which clotting factors? 2, 7, 9, 10. 2, 7, 9, 10. Now, we'll see here. As you can see, the vitamin K dependent factors have been encircled. As you can see, 2, 7, 9, 10. These are the vitamin K dependent factors which have been encircled. Okay, as you can see, encircled coagulation factors. These are the vitamin K dependent coagulation factors. So they are essential for biosynthesis of clotting factors 2, 7, 9, 10. 3 compounds of vitamin K. K1, which is present in the food, phytonadione, we obtain from the plant. Vitamin K2, which is fat soluble. Phylloquinone, which is produced in the gut by bacteria. Vitamin K2 is produced, which is fat soluble. Phylloquinone, produced in the gut by bacteria. Vitamin K3 is the synthetic one. Now, what are the various dietary sources of vitamin K? Green leafy vegetables, cabbage, spinach, liver, cheese. These are the dietary sources of vitamin K. Now, daily requirement is 50 to 100 microgram per day of vitamin K. Now, actions. Vitamin K act as a cofactor in a late stage synthesis and coagulation proteins by liver like prothrombin, factor number 7, 9, 10, or you can simply say 2, 7, 9, 10. Prothrombin, factor number 7, factor number 9 and factor number 10. These are the vitamin K dependent clotting factor. Means they plays very important role, or vitamin K act as a cofactor in the synthesis of these 2, 7, 9, 10 clotting factors. But whenever there is a deficiency of vitamin K due to malabsorption, long-term antimicrobial therapy, liver disease, obstructive jaundice, means there is a deficiency of vitamin K which may be due to malabsorption syndrome, long-term broad-spectrum antimicrobial therapy, liver diseases like cirrhosis of liver, obstructive jaundice. So deficiency of vitamin K can occur. If there is a deficiency of vitamin K, that means this vitamin K dependent clotting factors will not be there. If there is a vitamin K dependent clotting factors will not be there. So most important manifestation is the bleeding. Bleeding tendency due to lowering the level of prothrombin and other clotting factors. Means low level of the prothrombin and other clotting factors which may lead to bleeding tendency. And in that case, hematuria is usually the first sign to occur. The other common sites of bleeding are there is a hemoptysis, hematuria, hematomesis, epistaxis, ecchymosis. So GI bleed, nose bleed under the skin, that is called as the ecchymosis. So uses of vitamin K. If there is a dietary deficiency of vitamin K, you can use vitamin K analogs. If there is a prolonged antimicrobial therapy like broad spectrum antibiotics, so you have to use vitamin K. Liver diseases, obstructive jaundice, malabsorption syndrome, or if there is an overdose of vitamin, oral anticoagulant therapy, so that you can use vitamin K. So these are the various uses of vitamin K. Now in the newborns, what happens? They lack the intestinal flora. And if they lack intestinal flora, there is a low prothrombin level also. Okay, so they lack intestinal flora. There is a low level of prothrombin. So what we do, we give vitamin K 1 milligram intramuscularly soon after birth Why we give vitamin K 1 milligram intramuscularly soon after birth? Because newborn lack intestinal flora and there is a low level of prothrombin, and that's why we have to give this vitamin K 1 milligram intramuscularly soon after birth. Some prefer administering 5 to 10 milligram intramuscularly to the mother before 4 to 12 hours before delivery. And why we are doing all these things? To prevent hemorrhagic disease of newborn. To prevent hemorrhagic disease of newborn. Now, you can also use it in case of overdose of oral anticoagulant, that is the warfarin. Overdoses of warfarin, which is oral coagulant, phytonadione, which is a K1 analog of the vitamin K, is the preparation of choice. And those depend on the severity of the hypoprothrombemia, which is the measured international normalized ratio and bleeding. You can use fresh frozen plasma or whole blood, useful in most coagulation disorders. You have to use the whole blood or fresh plasma. Now, other coagulants in the form of fibrinogen. This fibrinogen is a pooled human plasma which control bleeding in hemophilia, antihemophilic globulin deficiency, and acute afibrinogenic states. Fibrinogen, pooled human plasma which control bleeding in hemophilia, antihemophilic globulin deficiency, and acute afibrinogenomic states. Antihemophilic factor, which is obtained from pooled human plasma or DNA recombinant technology, which is used in hemophilia and AHG deficiency. What is AHG deficiency? Anti-hemophilic globulin deficiency. Desmopressin, which is the analog of arginine, which releases factor number 8 and Wall-Willebrand factor from the vascular endothelium and checks bleeding in hemophilia and Wall-Willebrand disease. So desmopressin you can use. Ethamsilate, it reduces capillary bleeding when platelets are less. It exerts anti-hyaluronidase action or correct abnormalities of platelet adhesion and promote platelet aggregation by inhibiting PGI2. So you can use ethamsilate. So where we use these things for the prevention and treatment of capillary bleeding in menorrhagia, excessive bleeding in the menorrhagia, after abortion, postpartum hemorrhage, epistaxis, melena, hematuria, and after tooth extraction. So these are the different uses of coagulants where we have to stop the bleeding by using this vitamin K, fibrinogen, antihemophilic factor, desmopressin, ethamsilate. Now we have local haemostatics. Local haemostatics are also called as STYPTICS. Means generally what we do whenever there is some bleeding due to some sharp object or sharp cut, generally we give pressure on that particular site, and because of vasoconstriction bleeding stops, or we apply the ice cubes. Because of that ice cube, vasoconstriction occurs and there is a stoppage of bleeding. So substance used to stop bleeding from a local and approachable site. That site should be local and approachable, particularly effective on oozing surfaces like abrasion, tooth extraction, epistaxis, and epistaxis. It provides a meshwork which activates the clotting mechanism and checks bleeding and no foreign body reaction. It provides a meshwork which activates the clotting mechanism and check bleeding and no foreign body reaction. So astringent we can use, what is the astringent? Astringents like tannic acid, they precipitate the protein which is present inside the blood locally at the bleeding site. So astringent we can use. Thrombin powder, which is obtained from the bovine plasma. It may be applied as a dry powder or we can sprinkle over the wounds or bleeding site. Freshly prepared solution to the bleeding surface in hemophiliacs. It should not be injected because you use it as a powder, thrombin powder. Or simply we can use 0.1% adrenaline, which is soaked in a sterile cotton gauze. packed in a bleeding tooth socket or nose in case of epistaxis to check bleeding. When spontaneous vasoconstriction is inadequate, you can use 0.1% adrenaline. This adrenaline is contraindicated in hypertension, CCF, and acute myocardial infarction. Now we'll see the parenteral anticoagulants like heparin and its derivatives. Heparin was discovered by a medical student in 1916, and the name of that medical student is Maclean. Heparin was discovered by Maclean, and Maclean was the medical student. It was named heparin. Why the name heparin? Because it was first extracted from the liver. That's why the name heparin. Hepatic cells, hepatocytes. So heparin, it is extracted from the liver, and that's why the name. It is mucopolysaccharide which is found in the mast cells of liver, lungs, and intestinal mucosa. It is a mucopolysaccharide where it is found in the mast cells of liver, lungs, and intestinal mucosa. Heparin is the strongest acid in the body which is having electronegative charge. Heparin is the strongest acid in the body. So it is highly ionic, highly polarized. So it will not going to absorb orally. It will get excreted in the urine as such. It is a glycosaminoglycan. Heparin is a powerful anticoagulant that acts rapidly both in vivo and vitro. That means it can be used in laboratory as well as inside the body. Heparin is a powerful anticoagulant that acts rapidly both in vivo and vitro. Then parenteral anticoagulants like heparin and its derivatives. Heparin, or we can call it as unfractioned heparin or high molecular weight heparin, because this heparin is a straight chain mucopolysaccharide with a molecular weight of 10,000 to 20,000. It is a glycosaminoglycan which is extracted from a porcine intestinal mucosa. Glycosaminoglycan which is extracted from a porcine intestinal mucosa which is rich in mast cells. It is a strong electronegative charge compound, and commercially it is produced from the ox lung and pig intestinal mucosa. Now we'll see the mechanism of action. Heparin, it binds and accelerates the activity of antithrombin 3. What does it do? Heparin binds and accelerates the activity of antithrombin 3. So there is a complex formation, heparin antithrombin 3 complex, which inhibits the activated clotting factors like factor number 10, factor number 2, 9, 11, 12 and 13 by forming stable complexes with them. So simply heparin binds with the antithrombin 3. There is a formation of heparin antithrombin 3 complex, and they inhibit the activated clotting factors by forming stable complexes with them. And because of that, it inhibits the conversion of prothrombin to thrombin. So there will be no conversion of fibrinogen to the fibrin, and thus they prevent thrombus formation. Antiplatelet action of heparin is seen at a higher dose. They inhibit platelet aggregation and prolongs the bleeding time. It reduces the blood lipid level by releasing lipoprotein lipase enzyme from the vessel wall and tissues. So as you can see, mechanism of action of heparin, the effect of antithrombin 3. Okay, heparin binds to the antithrombin 3, or heparin activates, or you can simply say binds to the antithrombin 3. There is a formation of heparin antithrombin 3 complex which inhibit conversion of prothrombin to thrombin and fibrinogen to fibrin. So there will be no fibrin clot formation. It also inhibits the lipoprotein lipase. So it reduces the blood lipid level. It has also some antiplatelet activity at a higher dose. So as you can see, antithrombin 3, where it binds in the intrinsic pathway, it binds with the factor number 9, factor number 10, factor number 2. So that's how it acts. So heparin mechanism of action, as you can see, these are the active clotting factors. Active clotting factors with the help of antithrombin 3. It becomes inactive factors But when there is no heparin, this process is slow. When you add heparin, these active clotting factors become inactive with the help of antithrombin 3. But when you use with heparin, this process is very much rapid. Now pharmacokinetic properties: highly ionized molecule and large molecular weight because of highly polarized, strongly electronegative charged ionic molecule, and because of larger molecular weight they are not absorbed orally. Instant action when it is given intravenous infusion or intravenous intermittent injection for treatment. Subcutaneous route is preferred for the prophylaxis purpose. Hematomas with the intramuscular injection, so it is not preferred. Does not cross blood-brain barrier, no CNS effects. Do not cross placental barrier, so it is safe in pregnancy, or it's a drug of choice of as anticoagulant in pregnancy. It is metabolized in the liver by the heparinase enzyme and fragments are excreted in the urine. During heparin therapy, activated partial thromboplastin time monitoring is necessary, and it should be maintained at 1.5 to 2.5 times the control. Adverse effect: bleeding will be there due to overdose is the most serious and fatal hemorrhage. Bleeding is common. Hematuria is the first sign. Then heparin induced thrombocytopenia, HIT. Heparin induced thrombocytopenia, in that case you have to stop the heparin. Give an alternative anticoagulant such as lepiridine, bivalirudin, argatroban, fondaparinux. Do not give platelet transfusion because it's a heparin induced thrombocytopenia. Okay, so osteoporosis may develop on long-term use. There is a chance of hypersensitivity reaction in the form of rash, urticaria, fever. There is alopecia can also occur. Then contraindications: obviously it is contraindicated in the bleeding disorders. If there is history of heparin induced thrombocytopenia, they are contraindicated in the severe hypertension, threatened abortion, piles, GI ulcers, subacute bacterial endocarditis, larger malignancies, because there is a risk of bleeding in the central necrosed area of the tumor. Tuberculosis, there is a risk of hemoptysis. Ocular and neurosurgery, lumbar puncture. Aspirin and other antiplatelet drugs should be used very cautiously during heparin therapy. So these are all the contraindications, whether absolute or relative. So where we can use this heparin, therapeutic uses of heparin: we use heparin in the deep vein thrombosis and pulmonary embolism, unstable angina or acute myocardial infarction, angioplasty, coronary balloon angioplasty with or without stent, then atrial fibrillation, disseminated intravascular coagulation. So in all these cases we use heparin to prevent thrombosis, to prevent embolism, to prevent thrombosis. So it's a drug of choice for anticoagulation also during pregnancy. Now there is one more term that is called as the heparin resistance. This heparin resistance may be due to pharmacokinetic or pharmacodynamic reasons. Higher concentration of heparin binding proteins. Now there is a unnecessary high concentration of heparin binding proteins in the plasma, which competitively inhibits the binding of heparin to the antithrombin 3. So there will be no binding of heparin to antithrombin 3. So no heparin antithrombin 3 complex will be there, and heparin resistance is seen. Heparin's clearance may be accelerated in some patients that may lead to heparin resistance. Up to 25% heparin treated patients with venous thromboembolism require more than 35 units per day to achieve therapeutic activated partial thromboplastin time. Then congenital or acquired antithrombin deficiency or with elevated level of heparin binding protein. So these are the reasons for the heparin resistance. Now heparin overdose or heparin antagonist. Whenever there is a heparin overdose, you can go for the protamine sulfate. This protamine sulfate is nothing but the protein which is isolated from a fish salmon sperm. What is protamine sulfate? Protamine sulfate is a protein which isolated from a fish salmon sperm. It binds heparin with high affinity, and the resultant protamine heparin complexes are then cleared. If life-threatening hemorrhage occurs, heparin can rapidly reversed by the intravenous infusion of protamine sulfate. So it is given intravenously. It neutralizes heparin weight for weight. Means 1 milligram of protamine sulfate for every 100 unit of heparin. 1 milligram of protamine sulfate for every 100 units of heparin. So we have discussed the mechanism of action of heparin, uses, adverse effects, contraindications, heparin resistance, heparin antagonist. So this is all about heparin, which is a parenteral anticoagulant.